Hi, everyone. This is Carly over at the Kansas Health Institute. We'll get started in just a few minutes, but wanted to let you know two things. One, our agenda for today is what you are seeing screen shared on my screen now, and also wanted to let you know that we are now live on our YouTube channel. Thanks. Okay, good morning, everyone. This is Carly Houchin at the Kansas Health Institute. I show 11 o'clock, so I'm going to go ahead and get us started, and a pretty full agenda for the day. So we'll get started with some introductions in just a moment, and we'll provide a brief overview of the agenda here, as well as some of the materials that were shared in advance. But before I get into any of that, I want to see if Jenna from the revisor's office is ready to give us the statement on open meetings.
Yes, good morning, committee. This is Jenna Moyer, the Revisor Statutes Office. And due to health and safety concerns, members of the public are not in attendance at this meeting of the Special Committee on Mental Health Modernization and Reform Working Group on System Capacity and Transformation. But full access to this meeting is being conducted by a medium of interactive communication, allowing members of the public without cost to listen to the meeting through the use of live stream audio broadcasting on the internet and teleconference as available. This video can be accessed on the YouTube web page by searching for the Kansas Health Institute or KHI live channel. The agenda and all documents for this meeting have been provided by the Kansas Health. Additionally, a link to these documents has been provided in the comment section, of the YouTube video previously referenced. Each member of the working group and staff shall state their name and title each time the individual begins speaking or voting so that the individual can be readily identified by remote listeners. All participants are required to ensure that microphones, phones, or other electronic devices are muted when you're not speaking, so the ability of remote listeners or observers to hear proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive meeting pursuant to KSA 754319 and amendments thereto, and each motion, if any, will be clearly stated before the group votes, and the chairperson will announce the results of the final vote.
Okay, thank you. So this is Carly at KHI. I want to thank everyone for joining this meeting of the System Capacity and Transformation Working Group. Our agenda for the day is what you see shared on the screen here. Our primary topic is going to be system transformation. So we will spend some time in the agenda considering some of the existing system transformation recommendations that can be found in that crosswalk document of recommendations from previous reports. So we'll spend some time scoring some of those recommendations and developing new recommendations related to barriers that the group has previously brainstormed related to the topic of system transformation. Before we get into any of that, closer to the top of our agenda, we are going to have a quick wrap-up discussion on data systems, a topic that this group has previously taken up. What we'll be doing there is overviewing the results of a Qualtrics survey that a number of you participated in, just to check for consensus on those scoring and other things there. We'll jump into some introductions in just a moment, but wanted to remind everyone of our meeting commitments are at the bottom of our agenda here. So first, coming ready to discuss and compromise. We're going to work to keep our remarks succinct and on topic. We're going to speak up when we have any clarifying questions, and we will work to start and end on time. With that, I'd like to first run through the working group members who are on the line here so that everyone knows who we have joining us today. And to that end, the first person I'm seeing is Andrea.
Good morning, Andrea Clark with the Kansas Department for Aging and Disability Services Behavioral Health Services Commission.
Next, I see Kyle.
Good morning, I'm Kyle Kessler, Association of Community Mental Health Centers.
And Denise.
Hi everyone, Denise Sisman, Community Care Network of Kansas.
Representative Shu.
Hi, Representative Reese Shu, District 25, Northeast Johnson County.
Sandra Berg.
Good morning, it's Sandra Berg, the Behavioral Health Director for United Healthcare.
Spence.
Hi, Spence Cohen with the Office of Judicial Administration.
Representative Arnberger.
Good morning. My name is Tori Marie Arnberger, State Rep for 112th District, Great Bend and Hoisington.
And Representative Landwehr.
Representative Landwehr, 105th District, West Wichita.
Very good. I think those are the regular working group members. We are joined by a couple of supplemental experts who I will have introduce themselves in just a moment. But first, I want to see if I missed anyone. Okay, if not, we are joined by two additional experts today that the group recommended on the topic of system transformation. I'll call on you in just a moment, but if you could share a little bit about your background, some of the experiences that you bring to this topic with the group, so they know where you're coming from a little bit, that would be appreciated. And then also if there's any recommendations that you'd like to have on the radar for the group related to the topic of system transformation, those are welcome as well. So the first person I'm seeing is Robin Chadwick.
Hi, Robin Chadwick. I'm the president of Ascension Via Christi St. Joseph campus in Wichita. I've been part of the behavioral health service line for Via Christi for about 4 years. We have a large inpatient presence, outpatient presence as well, and was one of the 3 or so here in South Central Kansas that about 3 years ago began the Mental Health and Substance Abuse Coalition, which now includes a board of about 12 people and probably 30 to 40 community partners who are working on creating a better system to address mental health, substance abuse, and the resulting homelessness in this part of the state.
Great, thank you. And I think I also saw, are we joined by Sandra Dixon?
Hi, my name is Sandra Dixon. I'm Chief Clinical Officer at DECA. I'll tell you the same thing I said last week. I'm As Chief Clinical Officer, I oversee our 5 addiction treatment programs in the state, including our largest one in Wichita. Robin, you need to come see what your old building looks like now that we've moved in. We also sit on that Sedgwick County Planning Group. I also represent the Governor's Behavioral Health Services Planning Council. I sit on the executive team and am a member of the Supreme Court Task Force on Permanency Planning. We serve typically about 2,300 Kansans a year in substance use treatment and mental health services, and appreciate the opportunity to be part of this conversation.
Great. Any initial questions from the group for either of those two extra experts joining us today? If not, I will launch us into our first discussion item, which is related to wrapping up the discussion of data system recommendations. So let me get that on our screen here. Okay, and as a reminder, we are overviewing the results of a Qualtrics survey that some working group members participated in and just need to ensure consensus. So I will get us started with the recommendation that you see on the screen here. In the meeting on data systems, the group combined a couple of recommendations related to data collection and surveying. So the recommendation is to collect, analyze, use, and disseminate surveillance data to inform prevention, change legislation regarding public health and behavioral health state surveys, from an opt-in consent to an informed opt-out consent to allow for meaningful data collection. So via survey, the group gave this an ease of implementation score of 7 and a potential for high impact of 7 as well. Any additions, corrections, or edits there?
Hi, Carly, this is Kyle. And I apologize. I figured out yesterday why I was not receiving the surveys from you. It was going into a different folder automatically. So that's been reset. I shouldn't have any problem with that going forward. I probably would have had this in the 8 or 9 range, just because we've done it before. We know what the impact of this kind of information can be on prevention and recognizing hot spots and challenges. And with where we are almost every other week, there's a new study. This week's was from Mental Health America talking about the effects of COVID and suicidal thoughts. So I would probably raise that a little bit, and I suspect I would have had it around a 9 if I had filled out the aforementioned survey. So my apologies for that.
Okay, so this is Carlite, KHI. I'm making that edit on the screen there to a 9 for each. Any concern with that change from the rest of the group?
So Carly, I don't know this, but I have a concern with the change, and I understand the desire for this from the provider community, and you know, it might be something that we need to figure out. Is there a middle ground for this? Because I can see a lot of pushback on the opt-out piece. So I'm not saying we don't attempt it. I'm saying that, you know, we probably need to also look at, okay, what would be an alternative? What is a middle ground that we can come in with, maybe a compromise to make some people feel better about going from opt-in to opt-out?
Carly at KHI, any comments or edits from the rest of the group in response to Representative Landwehr's suggestion there?
This is Sandra Berg with United, and I was thinking the same thing, that the lower score really reflected the ease or the ability to change from an opt-in to an opt-out. I think the first part of it, collecting, analyzing, using the surveillance data, would be a 9, but I think that second part drops it down a little bit lower.
Okay.
Well, and I don't want to, you know, I'm not just trying to discourage the group, because I do understand the issue and why. So that's why I'm asking, is if you folks as providers see a middle ground. And for those of you that are in Topeka more frequently, probably understand where I'm coming from on this and my concern for changing that legislation.
I
don't know if there is a common ground. I don't know if there is one. So.
Yeah, Madam Chair, this is Kyle. is it possible to do something that provides additional information specific to this at the time of enrollment for the child so that people would have more information on the survey? Is that potential middle ground, or is that not middle enough?
Well, I don't know. We can attempt anything. I'm just saying that for the ease of passing
Yeah.
this,
Right.
there's going to have to be something because there's a reason that it went from opt-in to opt-out. And for those of you, again, that are up there in this process a lot, understand sometimes what we have to go up against in moving legislation forward. So I don't know if it's more information, you know, can we bullet point why this is important? That's why I'm asking you folks. I'm not saying we don't attempt it. I'm not saying that it's not a priority.
Got it. Thank you.
Okay, so this is Carly at KHI. I heard a couple of things in there. From Sandra, I think I heard bumping this down to at least an 8, splitting the difference from where we started to Kyle's comment. And then from Representative Landwehr, is there any interest from the group in adding any rationale items to address any of those concerns?
This is Andrea Clark with KDADS.
We can't understand you, Andrea.
Can you clarify that question? Are we
Andrea, this is Carly at KHI. I'm having a lot of trouble hearing you. I wonder if you want to try turning off your video and see if that improves your audio at all. Andrea, can you hear us now?
I can hear you. I've turned off my video. Is that any better?
That is helping.
Yes.
Thank you.
Okay. So I was just asking for clarification.
You may need to go out and come back in, Carly.
Yeah, Andrea, it's breaking. It's Andrea, this is Carly. Your audio is kind of breaking back up again. It might be helpful to leave the meeting and come right back in and see if that improves. For the rest of the group, are there any notes as far as rationale that we want to add at this point on this recommendation? Just in response to the comment from Representative Landwehr about the challenges around, I think maybe establishing consensus on this one.
As Andrea is probably logging back in, and others may have some opinion on this because of the relationship to prevention activities, but I think that some of what has driven this back to the forefront, and absolutely Chairwoman's right. I mean, there were reservations about the survey several years ago, but with what we've seen now from even our state suicide numbers, this is just one of the things that gives us additional information to try and prevent the continued increase and hopefully to get reductions in those numbers going. So this was just one of the pieces that was, from a funding standpoint, very, very low dollar investment and something that we thought could help with the prevention activities and again, preventing suicide and harmful situations for youth. It's something I think that also would benefit our school mental health programs that we've got going on, so that potentially some of those therapists and case managers and school liaisons would be able to see additional data relating to their school buildings and kind of giving them a heads up. So this on the ground floor at the community level, I think has benefits. I will keep giving some additional conversations with myself, thoughts about what some additional middle ground might look like, though.
Representative Landwehr, is your hand raised?
Yes, it is. And maybe one of the approaches in this could be from the providers is, what did this look like when the information was an opt-out? And then what has been the results with the opt-in, and why it's important to have what may have been lost. And this would be more, not so much for the people getting this report. This would be in trying to convey to other legislators as to why this may or may not be very important.
Okay, and Sydney has flagged for me a comment in our Qualtrics results that I will read for the group that may address some of this. The statement provided there, data from these surveys is statistically insignificant currently and not reliable enough to inform decisions under the opt-in change. Any other comments from the group, or are we comfortable with these notes at this point, recognizing that this is one where we'll likely need more discussion when we do that second pass over recommendations to land on high priorities?
Carly, this is Andrea Clark with KDADS. And just to build off of that comment, it has significant impact on KDAD's ability to do required federal block grant reporting on prevention activities. Being able to report out on metrics, et cetera, that are necessary for federal funding. So.
Thank you. I've made that note as well. In the interest of time, I'll maybe then move the group on to the next recommendation that we needed to review from the Qualtrics results. Get that on the screen here. And this one was from I believe the governor's substance use disorder task force, and has to do with the needs assessment. So a recommendation to conduct a statewide needs assessment to identify gaps in funding, access to SUD treatment providers, and identify specific policies to effectively utilize and integrate existing SUD treatment resources. So the ease of implementation score, the average score on the Qualtrics survey was a 7 for both ease of implementation and potential for high impact. Any additions, corrections, or edits to that from the group? Okay, not hearing any, so we'll have that one kind of stand as scored in that survey. The next one to discuss has to do with child welfare assessments. And I'll say, so the initial question that we're going to have here, we didn't have a good response via survey to this. So what we need to hear from the group is if this recommendation is an important part of what it would take to have a modernized behavioral health system. So basically, should we be considering this recommendation, or is it addressed elsewhere? And so the recommendation reads, based upon findings by the working group proposes future efforts to study strategies for engaging relatives to care for crossover youth, collecting data on outcomes for youth placed in group residential homes, and understanding whether youth who might have been detained prior to Senate Bill 367 are now being placed in the child welfare system. So kind of the first key question here, again, we didn't have a good response for this question via survey. Is this recommendation part of what it would take to have a modernized behavioral health system?
Carly, Brenda Landwehr here. You know, the issues in the recommendation are very valid. I would ask, was there discussion previously on how much may already have been gathered out there by the agency to highlight some of their problems? Because I think some of these items were supposedly addressed when the foster care lawsuit was dropped here a few months ago. So that would, to me, would indicate that somebody's got some data somewhere.
This is Carly. Oh, go ahead, Sandra.
This is Sandra Dixon at DECA. And Kyle, I have a question for you. I think you sat through the past few days of the foster care committee, and I'm curious if this conversation is occurring in that venue.
Yeah, I was just really racking my brain just on what the conversations were, Sandra. They did talk about this at some length, but I don't know if they ended up with a recommendation out of it last night, as they were, I think they were finishing up around 5:30 or 5:45 when I was there. But I think the chairwoman's right. It would be interesting to ask DCF specifically where this sits with data, but otherwise, as it relates to the underlying question of modernization, there was clearly an impact on the behavioral health system and Sandra would know better on the SUD side, but from what I hear from PRTFs and from CMHCs, there was a significant change in the acuity of the youth that they would see, and this was a significant part of that population.
Okay, so this is Carlite at KHI. Want to flag one thing quickly for the group, and then we can make a decision about how we would like to handle this. So at the time of the August special committee meeting, KLRB put together the crosswalk document. And then the one that we've subsequently shared out has all of the agency notes that were provided in testimony on that day. So related to this, at least at the time of that testimony, there were not comments provided. So we have no additional updates from DCF on this at this point in time. What I can do though is I can flag this for more information from DCF.
That's a good idea.
So that would kind of continue to table this recommendation for later discussion once we have more information, unless there is someone who's interested to move it forward in any way today.
Now, Brenda Landwehr here. Just want to make sure that, Carly, it's not an item we don't go back to because it's an important item. We just got to make sure we're not duplicating and find out what DCF already has gathered on this.
Okay, thank you. So what we'll plan to do, I'll get to this in some of our administrative updates at the end of the meeting, but you should have received calendar appointments for me to hold times, a couple of different times in November for follow-up meetings of this group. And what we'll plan to do in those meetings is kind of look at how we've scored everything, pull out our high priorities, and address some of these kind of miscellaneous pending items related to the topics we've taken up so far.
And this is Kyle. I want to say it's maybe House Bill 2274. That might have been part of the conversation because, of course, I left my notes in my car. But I think there actually is legislation maybe that was getting ready to go in front of the House Judiciary Committee before COVID took out the last legislative session. So the DCF people will be really helpful, I suspect. But if nothing else, briefly looking at that legislation to see how it would affect this, if I have the bill number right.
Let's see, Kyle, I just looked that bill up and it was initially about it's the effects of a medication abortion, maybe reversible. So I don't think that's it, but I will keep looking. It may be from
2774. Oh gosh, dang it. I apologize.
Kyle, I'll just make a note for myself to follow up there with you whenever you have your notes in front of you.
Great. I can give you a call later today.
And if I can find it in the next minute or so, I will let you.
A note from Arida, or it might be House Bill 2477. So I'll make that note so I don't lose it. But we will move on to our next discussion item here.
That's not it.
Okay. That the group scored via Qualtrics had to do with the state hospital electronic health record. This was a new recommendation that this group developed in your meeting on data systems. And that recommendation is that the new state hospital electronic health record system should be interoperable with other data systems in the state. Interoperability should include the ability to automate the current process to reinstate Medicaid benefits following discharge. And so the ease of implementation score that the group gave that via survey was 9, and the potential for high impact was also a 9. Any additions, corrections, or edits to those survey scores?
Okay, Carly, Brenda Landwehr here. Would this, is this the same issue as the health information exchange then? Or is this a separate issue?
I'm seeing working group members on mute, so I'll allow someone else to take the question if they. No, okay. I think this is.
I'm sorry, I thought somebody else had cheated on. This is Kyle Kessler again. So I think, Madam Chair, it's connected, but it's not the exact same. I think the hope had been that the new EHR for the state mental health hospitals would be interoperable so that they could feed information into the health information exchange, but it's not mutually exclusive.
All right, thank you.
And this is Carly at KHI. I think another specific component of what the group was maybe discussing in regard to this recommendation was the reinstatement of benefit piece following discharge. So ensuring that the new electronic health record was compatible with the CanCare eligibility system as well. Okay. Well, if there's not further discussion on that, that was our last kind of pending discussion item that we can address at this point on data systems. So I will stop that screen share and move the group to our discussion item for today, which is our recommendations related to system transformation. So this is the point in the agenda where it might be helpful to have that crosswalk document that I sent around as meeting materials. It's titled WG3 Crosswalk Agency. That will have all of the recommendations that we'll be discussing here. All of those will be listed there, along with the notes in blue is the information that the agencies provided when providing testimony to the special committee on these issues in August. So with that, what we'll aim to do here is review the recommendations that have been previously developed and score them using our recommendation rubric here. Similarly to past meetings, in sending this out, I did ask working group members if there were any recommendations that basically, had already been addressed or were being addressed by another group, etc. And so the first issues that I have flagged on our screen here are those that working group members thought we might be able to skip. So I'll give the group a minute to read the recommendation that we have on the screen here that comes from the Child Welfare System Task Force. And I'll just note that I had received feedback that we perhaps could skip this one. So we'll give folks about 20 seconds to read and then weigh in.
Brenda Landwehr here, I would agree with propose to skip.
Okay. With that, I'll go ahead and move the group.
Could I maybe make this is Kyle. Could we potentially at least put this on the shelf until later if we can come back to it potentially? And the only reason I say that is just because of how much the mental health center side and the CMHCs have been brought into this conversation just in the last couple of weeks. So I'm not sure, it doesn't belong in modernization conversations, but with this committee and this work group, but I also don't know that there's anything significant to add to it at this time.
Okay, so this is Carly at KHI. The note I'm going to make there is that this is a developing issue. Revisit at future meeting if possible. Does that sound okay, Kyle?
Just right.
And this is Andrea Clark with KDADS. I'd recommend maybe ruling this into the questions that we're tabling for DCF on the previous recommendation. Just in terms of getting more information as to where, if there are other groups that are working on this and what DCF's information is on it at this time. So I see them as kind of connected.
Okay. So I will, apologies, I'm passing along meeting entry information. Andrea, can I have you flag this for us when we get to that recommendation that may be connected as well?
Do you mean in terms of, this was the recommendation that we previously spoke of on the data systems?
Okay. I'll make that note for when we have further conversation there. Okay. The next recommendation related to this topic, there was a recommendation to combine this one with the next one. And so the first recommendation has to do with screening, brief intervention, and referral to treatment services for Medicaid eligible clients, specifically increasing healthcare linkages and identifying care transition best practices related to mental health, substance use disorders, and emergency departments across the state. There was a recommendation from a working group member to combine that with this other recommendation here from the Governor's Substance Use Disorder Task Force, again on SBIRT. So I can copy that up so we can see them at the same time, but any concern from the group with considering these recommendations as one?
This is Andrea Clark with KDADS, and I agree with combining the second half of the first recommendation regarding SBIRT, and there just being a single SBIRT recommendation if the committee chooses to pursue an SBIRT recommendation at all. And then taking the first piece, the increased healthcare linkages and identify care transitions, and combining that or looking at how it could be combined with the service integration recommendation under the column of SUD disorders or substance use disorders task force recommendations. I think those are, I think SBIRT can be a standalone issue, and then service integration and linkages to care can be a separate recommendation, or that makes sense to me at least.
Okay, let me find, so it was the service integration recommendation that we wanted to consider as a piece of this as well. So let me put that on the screen at the same time for folks. I'll do a quick scroll back up, apologies there. Okay, so what I heard from Andrea then is pulling out this first part and pairing it with the service integration, and then taking the second part related to SBIRT and having that go with the TR7 recommendation from the SUD task force. Is that an appropriate summary, Andrea?
That is my recommendation if other members agree.
Any discussion from the group on that? I'm kind of doing a rough cut of that on your screen now.
So this is Denise Sisman from Community Care. The second part of the first recommendation, which would be the adapting coding practices that allow for the integration of services, I see that as a little bit different than increasing healthcare linkages and identifying care transition best practices. So I guess it'd be helpful to have a little bit more clarification of how those two fit together.
Andrea, thoughts there?
Yeah. This is Andrea Clark with KDADS, and Denise, I agree with you. I kind of see them as two strategies under kind of one overarching recommendation of integration of behavioral health, physical health, substance use services, and that, you know, coding practices, that might be one way of doing it. Looking at linkages of care would be another way. You know, so I don't have any, I don't have any particular strong opinion on how that's worded or looked at. I just mostly wanted to split off SBIRT from that topic.
Yeah, so this is Denise again. I like that. I like if we could change the first recommendation to focus initially on integration, opportunities to expand and promote integration, and that these include, but are not limited to, some of these strategies. That makes sense.
Okay.
And I would just include then primary care and to go along with mental health, substance abuse, and emergency departments. Yeah, so that's it, right? If we could include that up in the beginning, that the integration goes across a wide range of types of providers.
Okay, I'm gonna fix that in a prettier manner later. I'll make that note there, Denise. But what I think I'm hearing from the group is we want to, for sure, pull out this SBIRT piece. Let me copy that one down. We'll score that in just a moment. But while I make that change, would like the group to start discussing how we might consider scoring that first piece of the recommendation. First, in regard to ease of implementation. So looking at the recommendation, it's messy, but hopefully the pieces are there. What considerations under ease of implementation do the group think describe this recommendation? What type of change? Program change, pilot program, program overhaul, new program, etc.
This is Robin, and I know I'm completely new to this group, so have very little knowledge of what you've talked about in the past, but what does this mean? Increase healthcare linkages? I don't know what that means.
This is Carlite at KHI. Is the group interested to make a language change there to make that more, say that we mean integration there? Denise, others?
This is Elizabeth Bishop. And I think what is missing, I'm trying to see it. Sorry, I've had an eye operation, so I'm peering at the screen, is the word collaboration. And that I believe that the best practices for mental health, substance use, and emergency departments is one of the things that, for instance, that CCBHCs are getting to, somewhat like wraparound services. And one of the reasons I think this needs to be scored high is I believe that this is the direction that mental health services are taking nationwide, and with a fair amount of push from the federal level. And looking at this really carefully will help to prepare us to take advantage of that.
And this is Denise Sisman. I agree with Representative Bishop. This is definitely, to me, this is the future of mental health mental health. I think I would also ask though to include the term integration, because it can be a combination of collaboration and integration. And that's happening with the community health centers as well as other primary care providers. I know my KU primary care physician also has an integrated primary care and behavioral health practice. And so we're going to be seeing this in the community mental health centers as they start to do more related to physical health. And also then we're seeing it on the other side. So I think that we have some good, strong history in this area and would recommend integration and collaboration.
This is Sandra Dixon with DECA. So this first piece of this came out of the Substance Use Task Force group, something that a few of us were involved behind the scenes. And it started from the consumer perspective. How do we create a system so there's potentially no wrong door? How do entities who provide differing services and are funded differently work better together to align that, so folks aren't having to bounce to multiple places to get their needs met? And I would concur the CCBHC model is one strategy for doing that. There are other strategies for doing that as well. So I do believe that the integration word, from the consumer perspective, how to make it easier, more timely, better outcomes, I think is really important.
Okay, so this is Carly at KHI. First, Representative Landwehr, is your hand still raised?
Yes, it is. And so I guess my question here, and maybe I'm missing something because to me it seems a little bit convoluted, is, Kyle, would this be kind of similar to when we talk about on a larger, different scale, but kind of like our case management within our CMHC system?
Some, I mean, it could be. I was having this conversation with former Secretary Bruffett the other day about how many different things or meanings there are to the word integration, because I think between the two of us, we came up with 5 or 4. And so I don't disagree with anything that Denise said, and Representative Bishop. I think that where this wording is currently at is about as simple as you can get it without trying to define integration, which probably is its own hour-and-a-half meeting. But I mean, I say that because 5-7 years ago, if someone asked me what integration was, I would have said, yeah, we've got to for sure get one meaning of behavioral health with SUD and mental health services available within one phone call. And then I was having a conversation with former Secretary Dr. Bob Mosier about integration. He said, yeah, absolutely. Physicians, clinics, and hospitals need to work together better. And I thought that's a whole different level of integration. But so probably for people like Denise and I, this is the conversation, is more of the case management services like Representative Landwehr mentioned, but also just the conversation from mental health to SUD to primary care and whatever role that takes, whether it's a quick referral, and that being the word linkage that was mentioned earlier, that Robin mentioned. And by the way, Robin, you don't get to lower the bar for you. There's only one person in this group that gets to lower expectations, and it's supposed to be me. Robin's extraordinarily bright and been around this longer than I have. But that's what I would say, that the linkage issue or term becomes really important, because that right next to integration, the terminology is very important. Trying to figure out that might mean a rapid referral system or something along those lines. That was a long answer to your question, but did I get close to it, Representative?
No, I think that you hit it on the head, and I would agree. This is something, I mean, I think it's definitely got a need for a high priority. It's almost as if it needs a subgroup discussion, like a subgroup within this group of some of the experts. I don't know, Kyle.
Yeah. And this is Denise too. I'm wondering if it would be helpful to look at SAMHSA's definition of an integrated mental health and substance use disorder system, because that might provide the framework that would be really important for us to consider. And I mean, absolutely, I agree with Kyle and with Representative Landwehr. There's lots of components and moving parts to this too. But luckily we have, the federal government at least, who has a integrated system in mind, and we can use that perhaps as a starting point.
And this is Sandra Berg with United. I want to tag on to what Denise just said. The SAMHSA model, the most integrated system is one that has co-location, common communication, management of clinical records. I mean, I've looked at the model, and if you're fully integrated, then you're able to bill across systems. Currently in Kansas, we have limitations within our systems of who can bill what services. So if one of the community mental health centers wanted to bill for and have somebody on staff to bill for primary care, they could not do that. Even within the FQHC system, Denise, stop me if I'm going down the wrong path, you have limitations as well too. So I think that's what's going to make the ease of implementation to a fully integrated system a little more difficult.
This is Carlite, KHI. Sandra, thank you for those comments. Would you care to put a number on, ease of implementation a little bit more difficult? Would you give us a starting point there?
I would say 7 as a start, depending on where you want to be in the continuum of integration.
Okay, and to clarify, a 10 recommended ease of implementation score 10 would be very easy. A 1 would be very challenging. So 7 is where we're starting.
So there's one of, yeah, Kyle.
No, I was going to say my original thought was 5 or 6, because we've been having these conversations for several years, and I think good faith conversations, and they go a bunch of different directions. Now the potential for high impact is a lot higher. That probably is in the 9 range, I think, for what that could mean for people in their home communities. And different systems of care. I mean, and stakeholders outside these systems like law enforcement, community hospitals would be in it, but even the impact on school districts and others.
So I was thinking a 7 as well. I think we do have a strong history of moving towards integration and using the SAMHSA model where there's the different points along the continuum. We have lots of experience with that. And then there's some good science that's out there as well. So what my first initial thought was a 7.
Heard a 5 and a couple of 7s so far. I'm going to keep a split at 6 for the moment. And Representative Landwehr, I see you with a hand raised.
And I guess my comment on that is my initial thought was a 5, and I was kind of surprised, Sandra, on the 7. I get where you're coming from, because it's got a lot of potential. Absolutely, it has that. And the same with you, Denise, and I think because of where we're at, probably the 6 would, because it's going to be tough, not impossible, but it's going to take a lot of work from a lot of people, and it's not going to be just legislators.
Well, and this is Sandra again. We have had to come up with some creative solutions to meet this need within different provider groups, and so it can be done. It just isn't implementable system-wide.
So this is Carly at KHI. We'll move us on to in just a moment, but wondered if the group could just quickly do some of the descriptive work, particularly in regard to the last question under ease of implementation. What types or what mechanisms may affect how achievable this is? What types? We've mentioned kind of a number of systems that would have to change in order for this recommendation to be implemented. I wondered if you all could direct me to which checkboxes we should select here.
So this is Denise. I'll start. It's a little bit tricky to answer this question because it does depend on what path you go down when you're talking about integration. So, but in the broadest terms, I could see that it could be part of a legislative session. It could also require a federal approval process if you're talking about the Medicaid state plan. Grant cycles, agency budget development. I think it depends on the route that you go down.
Thank you, Denise. Any other comments on maybe that particular section of the ease of implementation?
This is Andrea Clark with KDADS, and I would also include systems. I don't see any of those as being left off of what might be part of the integration decision.
Great, thank you. And now would direct the group. So I'd heard a 9 for potential for high impact tossed out. So we have that at the top. Any discussion on that, or would the group direct me any of our consideration boxes under potential for high impact? How should we describe this one?
This is Representative Bishop. I would also agree to a 9. I think it would have a high impact, and it's a matter of sorting out the various carrots and sticks to get a balance that actually serves the individuals in the mental health system and their families, and takes all of that into account. So I would score it very high in terms of high impact. I believe that's what the 9 means. I'm not sure which direction we're going in with that score, but I would say a high impact.
This is Carlite at KHI. Thank you, Representative Bishop. It's probably helpful to provide that framing. Potential for high impact, a high impact would benefit a lot of people, would be a 9 or a 10. So essentially across the board, a high score means good things. So it's easy to do and would benefit a lot of people. That would be something that was like an 18 or a 19 collective score. Any other discussion on potential for high impact?
Carly, this is Sandra with United. I think it would impact all of those populations, if you want to check all the boxes. And yes, it would serve those that are disproportionately impacted by the issue based on where they're living and the resources that are available. And I think it could produce savings. I think if we have less duplication across systems and we have more integration, linkage, handoffs to the right services, then we could see savings.
Okay, thank you for those comments. Maybe last call for comments or notes we should make on this recommendation at this point. Okay, we'll leave that there for now then. And we will now look at the, so as a reminder, this is the recommendation we just split off specific to SBIRT. So there's a couple different fragments here where that came up in a couple of places. But first want to ask the group, looking at this SBIRT recommendation on the screen, is this recommendation an important part of what it would take to have a modernized behavioral health system?
This is Sandra with United. I have a question for Andrea. Do you know, does CMS require the training for SBIRT? I know it's state required. Is that a CMS requirement as well?
I'm gonna say that I'm not comfortable saying what CMS requires on it. I mean, I know it's part of the KDAD's KDHE policy on billing, but that's state specific. And just, I'm not sure from this recommendation exactly what the recommended modifications that are being suggested here. So that would be probably helpful to me and determining whether or not this is a useful recommendation.
Yeah, so let's, this is Carly at KHI. Let's, as a group, seek to address Andrea's question there. What would we be attempting to accomplish with this recommendation, and how could we make that purpose then more clear in our language here?
So this is Sandra Dixon from DECA. Just some context. When SBIRT originally came to the state, one of the intents was it would be an available service in multiple types of locations for both Medicaid and block grant funded members. Currently, it's only billable to Medicaid and for some private insurance companies. So I think one of the conversations, at least in the SUD provider world and the prevention world, is kind of broadening the scope of who could facilitate SBIRT and be reimbursed for that. In other states, certified prevention specialists, for example, are able to do that. And the other recommendation has been to broaden who might reimburse for that. So to include it in block grant funding, for example, which has a farther reach for substance use than Medicaid does right now. So those are two things that I know have come up before.
This is Carly at KHI. I would pose that question to the group. Are we interested to add, I'd made note of two goals, at least in Sandra's comments. Are we interested to change recommendation language to make it more clear that this recommendation would specifically suggest that we broaden those who could administer SBIRT and broaden the reimbursement for SBIRT, specifically as an example, recommending that it be included in block grant funding? Are those changes the group's interested to make?
This is Andrea Clark with KDADS, and first I'd say yes, that those are changes we'd be interested in, but I do want to clarify that KDADS policy in regards to who can do SBIRT is only related to reimbursement and billing. So, you know, the KDADS doesn't have a position on who can do SBIRT generally, just who we're going to reimburse for the service. If that makes sense, clarifying when you talk about broadening who's doing this.
Okay, so this is Carly at KHI. I made a slight change to my notes then on Sandra's comment to say that we would be broadening the scope of who could administer SBIRT by, and I will change language so we don't have broadening twice, by basically changing how SBIRT is reimbursed for. And I would drop that into revised recommendation language.
And this is Andrea Clark with KDADS again. And I would also propose additional language around looking at innovative places to do SBIRT. I mean, when we're talking prevention, I know on the within some of the subcommittees on the Governor's Behavioral Health Services Planning Council, there's a lot of interest on SBIRT in the education system and in kind of other areas that, you know, potentially Medicaid or block grant funding aren't easily accessible, or there's not a clear path as to how we would reimburse it, but just looking broadly at how can we spread SBIRT throughout many different areas.
Okay, so this is Carly at KHI. I'll try and reflect what I'm hearing as far as a change here, and then maybe we can move into some scoring. So the language on our screen needs to be tidied up, but essentially we would be saying that we want to increase access to and utilization of SBIRT through a couple of specific strategies. One, broadening who could administer SBIRT by the mechanism of, you know, changing how we reimburse for SBIRT, specifically including it in block grant funding perhaps, and also to increase access and utilization, want to explore options to broaden where SBIRT could be administered, for example, the school setting. Did I miss anything there? Okay, if not, how would the group consider that for ease of implementation? Looking at the all of the checkboxes here, what would you, how would you have me describe this?
This is Kyle, and Sandra Dixon would know this better than me, but I think that this, again, this is kind of one of those, maybe a lower on ease of implementation, but higher for potential for impact. I can't remember when this was put in, but it seems like a long time ago, and we just make such slow inroads on it. And it could be that I have some pessimism to me relating to specific Medicaid initiatives, because that's not gone well for us with a couple of everything from health homes to housing and probably some other things that don't start with the letter H. But am I right that it's been around that long and we just haven't made some of the inroads, Sandra?
Yeah, this is Sandra Dixon at DECA. This started when Kim Nelson was still at KDADS, so that tells you how long it's been.
Well, it wasn't it with SRS even?
Yep. Yes.
Yeah.
Okay, so Kyle, this is Carly at KHI. Could you toss out, I heard a low ease of implementation score and a high score for potential for impact. Could you toss out a starting point number for us on either of those?
Starting point 5 for ease of implementation, potential for high impact 8 or 9.
Okay, discussion from the group on those?
This is Andrea Clark with KDADS, and I would agree with Kyle's assessment that at least in the Medicaid realm, SBIRT has been very, very slow to adaptation. That, you know, I think the focus really, what I would recommend the focus being on how can we approach SBIRT from other areas, you know, whether that's, as Sandra mentioned, block grant, or just other initiatives and settings to see what the impact can be. But there are definitely issues within the Medicaid system.
This is Carlite KHI. Thanks for those comments. What would affect ease of implementation? Any specific boxes I should check on in our left-hand column here?
Well, this is Andrea Clark with KDADS, and I would think potentially one avenue would be pilot program, and then, you know, SBIRT is a pretty standard process, so I don't know that you would consider it a new program, but it would just be overhaul and how it's delivered.
Okay, any specific mechanisms that may affect the achievability? What types of entities would need to be engaged to support this change? Would it require legislation, federal approval process, et cetera?
Andrea Clark with KDADS, and I'd suggest agency budget development, and potentially contracts, maybe grant cycles, in terms of looking at the block grant.
Great, thank you. And then just really quickly, how would we describe it in terms of potential for high impact? How are we thinking about scale here? What boxes should I check?
This is Denise from Community Care. I would say definitely yes for a large population.
Okay.
And I think most of the special populations would be impacted. I'm not an expert in SBIRT, so I'm not sure if it's appropriate for children. I don't know, Sandra or Kyle.
This is Sandra Dixon at DECA. There is a youth version of SBIRT. There's not an early childhood or latency age version of SBIRT.
Okay.
This is Sandra with United. Are we taking into consideration the follow-up piece that's in our recommendation? I think my focus has been on just the assessment part of SBIRT, but there's a component in there about follow-up.
So this is Carlite KHI. Can you say more about that question? Like, should that affect how we score it?
Well, that's why I'm asking. A model for follow-up with clients during this period should be implemented in Kansas. So yes, part of the program overhaul would be to include some type of follow-up after an SBIRT assessment. And I mean, it's very brief. So after that period is over, then what?
This is Sandra Dixon at DECA.
Oh, go ahead, Sandra.
So to the other Sandra, I think that sentence might have gone with that other recommendation about integrated service delivery, talking about people coming out of substance use, mental health, emergency rooms, and the risk for suicide at that time. I think that sentence might go with the other recommendation.
Okay, so this is Carly at KHI. I've crossed through that portion. Sandra, does that address the question there, or is there an additional change that would be helpful?
No, I think the other Sandra is correct that it probably should have belonged with the other one. I'm looking through the original recommendation and I don't see follow-up mentioned. So that's good.
Okay. Then I'll maybe make a last call for any comments related to this recommendation. If not, we can move on to our next one. Okay, not hearing any. There is again a recommendation here to combine recommendations. This first one reads, Kansas needs to formulate a team of coordinators, champions, regional trainers, and MCOs that will support and ensure the facilitation and stability of integrated evidence-based practices. So that's the first recommendation. And then the next one, I hope I have this note correct. So working group members, if this was from you, correct me if I'm wrong. The recommendation that I had a note that there was a suggestion to combine is what's on the screen here related to comprehensive housing, which reads expand an array of housing that would include a range of options from residential care facilities, long-term and transitional supported housing, independent housing units following evidence-based practices and principles such as permanent supportive housing, home ownership, and then some information about state contracts and Medicaid funding related there as well. So first, is the group interested to find a way to combine those recommendations?
And Carly, this is Sandra with United. I made that recommendation with the umbrella of evidence-based practices being over the sub topics of housing, supported employment, whatever else they had listed there. So I see evidence-based practice as the overarching umbrella, and then having those pieces as sub topics.
Discussion from the group on combining those?
This is Andrea Clark with KDADS. And I agree with Sandra's suggestion that having an overarching umbrella of emphasis on evidence-based practices, and then wrapping that into including around housing, supported employment, et cetera. I would make the suggestion on the recommendation language regarding to formulating a team of champions that the Governor's Behavioral Health Services Planning Council has worked to establish a subcommittee on evidence-based practices that I think effectively is that team of coordinators, champions, potentially regional trainers, and that the recommendation focus on continuing to support the use of EVPs in the state, including supporting fidelity.
Okay, so changing, this is Carlite, Andrea, based on that, some kind of change to the start of recommendation to make it clear that it would be a need for Kansas to maybe continue to support use of evidence-based practices in the state, including fidelity to those practices. And then we could move into listing supported employment, supportive housing, et cetera, as the examples of evidence-based practices. Is the group comfortable with the change in that direction?
This is Denise from Community Care. I'm very comfortable with the change. I wonder if it would be helpful though to, where it says Kansas needs to continue to support, would we want to say continue or expand? Is this something that we would want to see us doing more of?
Andrea Clark with KDAD's votes for expand as well.
This is Sandra with United. I want to say something about fidelity. When you're talking about fidelity, Andrea, are you meaning full fidelity or leading to a fidelity? We had this discussion when Misty Bogart started. He was leading a work group around what it means to work to fidelity on some of these evidence-based practices. It can be very costly. Some of them have high costs around staff to member ratio and those types of things. So I want us to move towards fidelity, but not have it as a requirement.
This is Sandra Dixon at DECA. I want to chime in on that one. Having been at that evidence-based subcommittee a couple times, one of the conversations from a provider perspective is coordination of evidence-based practice fidelity. Multiple funders will require different evidence-based models, and they're all expensive. And sometimes they can't be used at cross purposes. Sandra Berg and I just had this conversation not too long ago. So as a state, I think we should support continued use expansion, but I would encourage us to also think about coordination among systems. And the criminal justice system requires a specific model. Somebody else might require a different model, and it's really challenging for providers, no matter what service you offer, to meet fidelity with all of that at the same time.
Okay, made notes there to try and add that note of coordination. And I also heard something from you, Sandra Berg, that I want to make sure to not lose about referring to fidelity as a goal to move towards, but recognizing the barriers there.
And Sandra, I agree with that. I mean, I think recognizing it as a goal to move towards, it is a big, it's a lot to bite off.
Mm-hmm. So this is Carly at KHI. In the interest of time, we'll iron out some of this language, try and having all of those pieces in there, but we'll send it to you all as that Qualtrics survey, and we'll score it there. So any other concept that you would like to make sure lands in this new recommendation here about evidence-based practices? If not, we will move to, we'll score this one via survey, and we'll move to discussion of some new recommendations related to this topic of system transformation. Okay. So in our very first meeting of this group, we spent some time brainstorming barriers to, in this case, barriers to transforming the behavioral health system. So what you're looking at on your screen now is those list of barriers that you all came up with in that initial meeting. Our task at this point is to come up with new recommendations that did not come up in any of those previous reports. So in that crosswalk document, basically what recommendations do we need that previous groups did not make. So new recommendations is the goal of this part of our agenda. I'll run quickly through these barriers as to give folks a minute to think through and be a good starting point for this conversation on new recommendations. So one of the barriers the group initially brainstormed for the topic related to system transformation is cross-system collaboration. So there are barriers currently to cross-system collaboration. Any recommendations the group wants to make to address that? Another barrier was treating people in the court system the same as anyone else when it comes to cost. So how I think how treatment for those involved with the court system is funded. A barrier noted was the need for significant infrastructure changes to support some level of integration. Another barrier was lack of capacity, I think, in the system overall. And the specific note I had here was for a regional residential facility in South Central Kansas. Another barrier the group noted related to this topic was Medicaid payment structure that supports parent only, the barrier is Medicaid payment structure for parent support is only available when the child is the primary client. And the need the group articulated was to support families through the overall system of mental health. And then again, this is a little bit of a repeat comment, but the other barrier that the group listed was the lack of infrastructure generally in the system that prevents it from being possible to sustain progress. Okay, so I think I'm seeing maybe Kyle has his hand raised to kick us off on this discussion of new recommendations.
Thanks, Carly. And this is Kyle Kessler. I have two that really are at the bookends of the conversation, starting with the Medicaid structure supporting the billing of the client or the child with only the parents, foster parents present. This was a significant conversation topic during the Foster Care Oversight Committee, but really belongs, I think, with this committee and also probably at the Bethel Cane Care Oversight Committee, but that's code 90846. There was specific testimony on it by one of the CMHC executives from Wyandotte County who's been who's done this kind of work and talked about it not even being, because the question was asked about staffing, and he said, well, this is just an additional tool in the toolbox for helping youth in foster care and other vulnerable youth. So I think that this is something that in my mind is low-hanging fruit, but we've also treated it like low-hanging fruit for 5 years, which is why we've tried to start engaging the legislative branch more in the conversation. And so I think this is something that could be very helpful, especially in our foster care systems and during the current COVID and post-COVID eras. Then the other side of the coin is the state mental health hospitals. I know we have several updates from KDADs, but to look at the inpatient systems, that's something that I think this work group has to have the conversation about. In the South Central Kansas Regional Residential Facility, to see how now, I think, and Representatives Landwehr and Bishop and Robin might see this still a little differently, but I think that KVC hospital has helped tremendously, and St. Joe's has a kids inpatient psych unit down there, I believe still, and that's a substantial sea change for the South Central Kansas area in the last 3 years. I think both of those have come online, whereas they had nothing, no PRTFs. The closest PRTF was 40 miles from Wichita at one point. So to think about what that's done for the kid system, what if we did something like that for the adult side too? And certainly the ComCare crisis, the relationship between Via Christi and ComCare and Substance Abuse Central Kansas and now DECA being there, I think those are all very important. But we're at a crisis point, and I think both our inpatient kids and inpatient adults systems, we've said that for a while, but I'm going to start beating that drum again. And again, Western Kansas, I hear about that at least twice a week with the lack of inpatient resources there. So I think that has to be the part of the continuum of care that doesn't get lost.
This is Sandra with United. I'd like to add to what Kyle said around the 90846 or something equivalent, especially for children who go into a PRTF. When they enter the PRTF, the medical card is closed to any outside billing. And a lot of times we see that the family still needs support while that child is away to prepare them for the child to come back. And that just isn't available right now. So it doesn't just impact youth in foster care, but it impacts any child who goes into a PRTF that would need, that family needs that additional support.
From Via Christi's perspective, it seems like most of the kids in foster care end up at KVC and then into their system. We tend to see, we still see kids that are in foster care, but I would say our percentage of kids in foster care is significantly lower than KVC sees. So we don't struggle with that PRTF issue as much. On the adult side, it's a completely different story. We have our biggest need on the inpatient side for adults is long-term care facilities that will accept patients. We sometimes wait 20, 30, 50, 60 days to find placement for a patient in a long-term care facility. The longest one I've ever talked about is 15 months. We had him waiting for someone to take him. But our length of stay for those patients can easily be 2 to 3 months waiting for a level 2 mental health nursing home to accept a patient. If it's a quote easy patient, it may be a little bit shorter, but a patient with any kind of criminal issue in their history, specifically any kind of sexual predator, any issues related to sexual activity, it is almost impossible to get those patients placed in a timely way. And as I've had the conversation with the team from KDADS many times recently, that has a big ripple impact because at any given moment at St. Joe, we may have, on average, we've got 10 adults waiting for inpatient placement in our adult unit. Our average length of boarding time, once that decision is made, is about 11 hours. Once they've been through the whole assessment process. Generally, our longest in a month at any given point is about 110 to 120 hours that they wait for placement upstairs in a bed. But on average, we've been able to bring that down to around 10 to 11 hours. But the fact that we're holding patients upstairs for 2 or 3 months waiting on a long-term care bed means those beds are not available for those patients waiting in the ER. So it's a big throughput issue. So that's our biggest need is long-term care access. Second big need, and we've talked about this many times over the last 3 or 4 years, is a smaller version of a state hospital somewhere in Sedgwick County. Because every time Via Christi transfers a patient to Osawatomie, we have an $800 transportation bill, which just increases the cost of healthcare.
Robin, what are the EMTALA potential for psychiatric violations and relating to psychiatric boarding?
You know, as long as we are doing everything we can to keep patients safe and we are getting them moved upstairs in some sort of a process, and we have a internal process for working with our own internal bed placement, and we accept those referrals from external ERs, from communities across Kansas, and so they just go into the queue. We try really hard not to only take our patients from the ER, but to also help other communities and other hospitals unload their ERs. So yeah. I worry about EMTALA issues all the time, but we figure out ways to do the best we can, because they don't stop coming.
I asked my question really badly because for you all, knowing what you do and having the expertise that you do, you're in a very different situation than a smaller hospital that doesn't have a psych unit or some sort of access. So would you envision it to be much more significant risk for other hospitals that aren't you guys? Maybe that's a better way for me to ask it.
Yeah, if I was in a smaller facility with no access to resources for psychiatric care, I'd be real worried.
Thanks.
Okay, this is Carly at KHI. I just want to check in on how I have my notes reflected on the screen right here. We just have a couple of minutes before we need to get to some administrative updates. The highest level, the new recommendations that I've heard from this group is the need for an adult care crisis facility, particularly for inpatient care, and one that is a long-term care facility accepting patients as well. I think that one is particular to South Central Kansas. But if I have that, if that's an incorrect assumption, please let me know. The additional note I've made is that it is currently particularly hard to place patients in those long-term care facilities if they have past involvement with criminal justice system or any history of violence. Also have made note that the group said there is a need for some kind of state hospital satellite in Sedgwick County. And the specific note that I had there is the current high transportation costs to existing hospitals. And then the third new recommendation that I heard from the group was to enable utilization of Medicaid code 90846, as that is seen as a tool to help not only youth in foster care, but the family of any child and subsequently the child of any one accessing care in a PRTF. Additions or corrections to those high level new recommendations?
Carly, this is Sandra with United. I just want to add for the lack of capacity, yet I agree with all of that, and that we have that issue in other places within the state with folks that are very difficult to place. We've had 2 of our members sit at KU Hospital for over a year because there was no place for them to go.
Okay.
So yes, it's an issue with the hospital bed space in that region of the state, but it's also a larger issue with people who are really difficult to place and finding the right place for them that will take them.
Great, thanks. I've made that note. And I think Representative Landwehr, your hand is raised as well.
I think, Carly, when you made the comment that referring to South Central Kansas means Sedgwick County, and I think that's probably where the location might be, is I foresee, and the experts can correct me if I'm wrong, that it would be able then to serve from the east to the west borders in South Central Kansas.
And this is Kyle Kessler. And Robin knows this off the top of her head, I'm sure, but I think even with the crisis center now, if you envision that kind of a facility serving South Central Kansas, I believe that the ComCare crisis program serves not just Sedgwick County, but I want to say Sumner, Butler, and maybe Harvey. Does that sound right, Robin?
It does. I'm not sure if that, I'm not positive those are the right counties, but it's 4.
Thanks.
I apologize. I'm going to have to jump off because I have to go lead a 12:30 meeting.
Thank you, Robin.
Thanks, Robin.
Thank you for your invitation to join you.
Thank you for joining, Robin. Your insight has been very valuable. On that note, I'll maybe just say one last call, comments on these new recommendations. If not, I do have a couple of administrative updates before we wrap here in about 1 minute.
This is Andrea Clark with KDADS, and can I suggest just expanding on that recommendation across the whole continuum of care, that I think that the backup doesn't stop at the long-term care facilities. Accepting patients, part of that is a problem of being able to move those individuals into supported placements in the community when appropriate. So there's several points at which the system gets clogged because there's not a place for someone to go, and therefore you see that kind of backup all the way up to the crisis center.
Yeah, and this is Andy Brown with KDADS, and I would echo that. I mean, we do have a significant problem with, the majority of our long-term care facilities are full. Right. It's not a matter of people just being turned down. We literally don't have spaces for them because we have people that have been in them for 10 plus years. And there's a real need for us to be able to open the back door on those facilities and get those people back into the community with supported housing, supported employment, and other community-based services so that they can have a stable life outside of an institution.
And this is Kyle Kessler. I might add, just if I could real quickly, Carly, the things relating to that, again, this kind of goes back to my previous comment about the challenges with housing programs and getting those approved through Medicaid. There's a great program next door in Missouri that has almost helped them eliminate the need for inpatient referrals for state hospitalization. My frustration is when we tried to get that passed several years ago, and I know KDADS has tried to do more and more, but essentially the KDADS, the KDHE Medicaid response was, this would be really hard and it might draw scrutiny from CMS. Well, if we're not going to use our managed care companies to help keep us out of that and look at medical necessity, then we're not taking advantage of the full array of tools we have at our disposal anyway. So we're going to, and this connects to my original last point, which was going to be, I think that it may be that the chairwoman would rather have this conversation with the larger group, but if we could get the reviser to talk a little bit about Article 7, Section 1 of the state's constitution, not to give necessarily an opinion, but to say, hey, this is what this says, and maybe a little of the history on it, that would be, I think, pretty beneficial, because we don't have the right programs available for the back door. I mean, they're light at best, but I don't think we're doing all that we could do if we were able to implement them, that Missouri model.
Okay, so this is Carly at KHI. Only in the interest of time, I'll jump in there and I will maybe direct that question, Kyle, about additional information on Article 7 to another format, just again, only in the interest of time here today.
Sure.
And then just very quickly, I think I want to give 3 very quick administrative reminders before we adjourn here. So first, you should have seen in the email I sent with materials for this meeting, the group has decided to split out the topic of telehealth and address it in a subgroup with individuals from each of the 3 working groups. As we realized in pulling that group together, a lot of the supplemental experts were going to be the same people, and rather than pulling those people into 3 different meetings over the course of about a week, we wanted to have that conversation all in one place. So what I'm doing is asking for volunteers from each working group who are interested to participate on that telehealth subgroup. I'm happy to jot those names down now, or you can send me an email, whichever you prefer.
Carly, this is Sandra with United. I would like to be a part of that.
Great.
Denise with Community Care also.
Great.
And this is Kyle, I would as well.
Very good. So I've made those 3 names, and anyone else, there's a doodle poll in that scheduling poll, or excuse me, in that email where I included that initial information. If you want to go ahead and participate in that, we're going to try and find time the week of November 9th for that group to come together. But again, if you're interested to participate and you didn't get a chance to chime in there, feel free to shoot me an email. The second administrative item before we adjourn, we will have another Qualtrics survey to wrap up discussion on this topic, system transformation, just to do some light scoring of the remaining recommendations. So keep an eye out for that. Also still pending the Qualtrics survey for the topic of our last meeting, which was interactions with legal system and law enforcement. I didn't want to try and wrap up 2 conversations in one meeting. So that Qualtrics survey, just so you're aware, is still open, and we'll address that at a future meeting. And then look for a new survey from me wrapping up the conversation from today on system transformation. And then very lastly, want to be sure to remind the group that the next meeting of the full special committee is October 30th. I'll plan to work with Kyle and Andrea as the chair and the vice chair to try and get a report out from this working group, just kind of telling that group a little bit about what we've been up to. But then also want to flag for everyone else that similarly to the last special committee, we will be having some conversation in that format about our vision for a modernized behavioral health system and working to articulate what that means in regard to kind of each of the topics that we're addressing. So we'll just ask that people come ready to weigh in about a vision for what modernization looks like. Want to pause to see if there's any questions on any of those items. Okay, not hearing any. Thank you guys for hanging in there a little bit late today. So apologies for going over there. Want to thank both Robin and Sandra for weighing in with their expertise related to this topic today. And thank you to regular working group members for joining as well. And we will talk soon. We're adjourned.
Thanks, Carly.